Good afternoon, ladies and gentlemen. I would like to present you my PhD thesis titled Impact of Cardiac Markers Values and Ischemic Time on Mortality in Patients with ST Segment Elevation Myocardial Infarction Treated with Primary Angioplasty, Analysis of 270 Patients. Cardiovascular events are among the leading causes of death worldwide. Our department treats between 250 and 300 patients with ST segment elevation myocardial infarction every year. The aim of this study was to analyze 30 days hospital and 1 year mortality of patients with acute STEMI treated at our department with primary coronary angioplasty and the influence of factors, shock, troponin, natriuretic peptides, creatine kinase, and ischemic time on patients' mortality. We analyzed a group of 270 patients treated with primary PCI between April 1st, 2018 and March 31st, 2019. Here is a table with the detailed characteristic of a whole group. We can see that mean age was around 67 years, 70% were male. If we are talking about coronary occlusion and culprit lesion, in first place it was ramus interventricularis anterior, left anterior descendant, around 46%. In the second position, it was arteria coronaria dextra, right coronary artery, 37%. And in third position, it was left circumflex, 12%. Mean ischemic time to revascularization was 203 minutes. 18% of patients were in cardiogenic shock. Mean ejection fraction of left ventricle was 46.4%. 62% had hypertension, 37% had diabetes. Mean BMI was around 28. Mean LDL cholesterol was around 3. And if we are talking about laboratory parameters, median of creatine kinase was 14.9. Median of troponin was 2,444, and median of natriuretic peptide was 538. 1 year mortality was analyzed using Kaplan-Meier method. On the left side, we can see a Kaplan-Meier curve. Group 0, blue one, no-shock patients. Group 1, cardiogenic shock patients. And 1 year mortality between cardiogenic shock and no-shock patients was statistically significant at the level 0.05. In these two tables, we can see hospital and 30 days mortality. The numbers are very similar. We use Fisher-Exact two-tail test. And again, 30 days and hospital mortality between cardiogenic shock and no-shock patients was statistically significant at the level 0.05. Comparison of selected parameters, again, shock versus no-shock patients. In this table, we have some parameters: age, sex, left ventricle ejection fraction, ischemic time, creatine kinase, troponin, and natriuretic peptides. And we can see that statistically significant at the level 0.05 were left ventricle ejection fraction, ischemic time, and natriuretic peptides. We already know that shock patients had worse survival than no-shock patients. Shock is associated with survival, and we wanted to know if there are other parameters which could be also associated with survival. And we can see here that statistically significant was age. Age is associated with survival, then sex is associated with survival, Female gender is more risky than male. Cardiogenic shock, left ventricle ejection fraction, and natriuretic peptides. Troponin came out with borderline significance, but not significant at the level 0.05. And ischemic time is not associated with survival because it's not an independent factor, but depends on patient's condition. Discussion and conclusion. In all cases, 30 days hospital and 1 year mortality. Shock patients had worse survival than no-shock patients. Shock and no-shock patients different in mortality and a number of other parameters. Natriuretic peptides, ischemic time, and left ventricle ejection fraction. And if we are talking about influence on survival, age, sex, left ventricle ejection fraction, natriuretic peptides were associated with survival. Troponin T came out with borderline significance. And ischemic time, it's not associated with survival because it's not an independent factor, but depends on patient's condition. Thank you for your attention.
Excellent presentation, super important condition, and really interesting data. Just while we're waiting for questions, I have a question as to how you define time, ischemic time. Was that the time from the diagnosis to revascularization, or time from symptom onset?
Ischemic time begins with chest pain, and it's until insufflation balloon in coronary artery in cath lab.
So it does encompass pre-hospital chest pain. Okay, that's great. And I guess my general question is, based on your findings, has this influenced your practice in your center? Do you still measure this panel of biomarkers in all patients with STEMI, or have you refined your thinking as a consequence of your findings?
We use it in our clinic.
And which ones do you find most helpful in practice? Most helpful,
troponin and maybe the creatine kinase, if we are talking about myocardial infarction, how big it is.
Okay, so you still like creatine kinase. That's fine. Everyone's allowed to have their favorite biomarker. Any questions from the floor? Well, if there are no more questions, we'll draw that session to a close. Thank you very much for an excellent presentation to all the speakers.